I think this is also an exciting area of development in AML maintenance. So maintenance therapy following transplant in the hopes of decreasing rates of relapse, suppressing residual disease, and hopefully curing those patients, which ultimately is the goal of transplant. But unfortunately, we don't accomplish that currently in all patients. So maintenance therapy historically has been challenging because we only have cytotoxic therapies, which in the post-transplant setting, these patients that are vulnerable with immune marrow, it's hard to hit them again with intensive therapy. So newer novel therapies that are more gentle, more targeted, seem to be better placed in this setting. And among these are FLT3 inhibitors, which have already been studied in multiple clinical trials and seem to show a significant amount of promise and are being increasingly and more pervasively used as maintenance following transplant, but also IDH inhibitors that are also well tolerated and may in time play a role in patients with IDH mutated disease. We conducted 2 parallel studies, one with Enasidenib, the IDH2 inhibitor in IDH2 mutated patients, one with Ivosidenib, the one you mentioned, in IDH1 mutated AML as maintenance. Both studies accrued at the same time, and both were dose-finding phase 1 studies. And both suggested tolerability and some early suggestion of activity versus historical data. But we need larger, more advanced phase clinical trials, similar to what we've seen with the FLT3 experience in IDH, with IDH inhibitors, to be better able to tell whether there is real promise there as maintenance post-transplant.